The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound powered by React's collaborative platform. Innovation and you. Philips.
Ban tổ chức gồm Hội Hồi sức cấp cứu và chống độc Việt Nam và Philips Việt Nam. Chúng tôi xin được gửi lời chào trân trọng nhất đến toàn thể quý bác sĩ đang tham dự buổi hội thảo trực tuyến ngày hôm nay. Với chủ đề ứng dụng siêu âm phổi trong hồi sức cấp cứu, vì sao, khi nào và làm thế nào, Philips Việt Nam hân hạnh được hợp tác với Hội Hồi sức cấp cứu và chống độc Việt Nam với mong muốn cùng quý bác sĩ đưa ra câu trả lời cho các câu hỏi của chủ đề và đồng thời cập nhật tới quý bác sĩ những ứng dụng siêu âm phổi trong hồi sức cấp cứu trên thế giới cũng như tại Việt Nam vào những năm gần đây. Sau đây là nội dung của chương trình. Tiếp đến, chúng tôi xin trân trọng giới thiệu đến quý bác sĩ sự góp mặt của các chuyên gia trong hội thảo ngày hôm nay. Khách mời danh dự của chúng tôi, giáo sư tiến sĩ Nguyễn Gia Bình, Chủ tịch Hội Hồi sức cấp cứu và chống độc Việt Nam và là nguyên trưởng khoa hồi sức tích cực Bệnh viện Bạch Mai. Chủ tọa hội thảo hôm nay, thạc sĩ bác sĩ Đỗ Hồng Anh, Fellow in Emergency Critical Care Ultrasound tại Đại học UiTM ở Malaysia. Cùng tiến sĩ bác sĩ Luna Gargani, bác sĩ tim mạch và là nhà nghiên cứu lâm sàng tại Viện Sinh lý lâm sàng của Hội đồng Nghiên cứu Quốc gia Pisa, Ý. Sau đây, xin được kính mời giáo sư tiến sĩ Nguyễn Gia Bình có đôi lời phát biểu khai mạc hội thảo.
Xin kính chào các bạn đồng nghiệp thân mến. Hôm nay tôi rất là vui mừng được giới thiệu với các bạn một cái chương trình đào tạo online với sự giúp đỡ của công ty Philips với vai trò của siêu âm trong hồi sức cấp cứu. Như các bạn đã biết là trong dịch Covid-19 vừa qua, rất nhiều các bệnh nhân nặng, đặc biệt là các tổn thương phổi. Bình thường thì chúng ta có thể sử dụng các cái chụp phim thông thường, X-quang hay là chụp CT scan. Tuy nhiên đối với các bệnh nhân nặng, đặc biệt các bệnh nhân lây nhiễm, việc di chuyển các bệnh nhân và áp dụng các biện pháp phòng hộ để đảm bảo an toàn cho người bệnh cũng như là hạn chế sự khuếch tán từ nhân viên y tế không dễ chút nào. Trong khi đó chúng ta có một vũ khí rất là đáng tin cậy, đó là siêu âm. Siêu âm đóng vai trò rất là tốt trong giúp cho chẩn đoán theo dõi tình trạng viêm phổi. Siêu âm giúp cho đánh giá cái tình trạng về huyết động, cho nên là vai trò của siêu âm nó rất là quan trọng. Hôm nay tôi xin giới thiệu hai báo cáo viên, đó một là thạc sĩ bác sĩ Đỗ Hồng Anh, một người rất đam mê trong lĩnh vực siêu âm, ứng dụng các siêu âm trong lĩnh vực hồi sức cấp cứu. Thứ hai là giáo sư Gargani từ bên Italia, là một người rất là có kinh nghiệm. Thì chúng tôi xin trân trọng kính mời hai vị báo cáo viên bắt đầu.
Xin cảm ơn những lời chia sẻ của giáo sư tiến sĩ Nguyễn Gia Bình. Tiếp theo xin kính mời thạc sĩ bác sĩ Đỗ Hồng Anh giới thiệu đôi nét về ứng dụng siêu âm trong hồi sức cấp cứu tại Việt Nam và lý lịch khoa học của tiến sĩ bác sĩ Luna Gargani. Xin mời bác ạ.
Xin kính chào tất cả các quý đồng nghiệp. Hôm nay tôi rất vinh dự được tham gia cái hội thảo này với sự giúp đỡ của Philips, sản phẩm Philips POC và Hội Hồi sức cấp cứu Việt Nam. Trước tiên tôi xin giới thiệu về speaker chính của chúng ta ngày hôm nay, đó là tiến sĩ Dr. Luna Gargani. Bà là một thành viên của Hội đồng khoa học của Hội chẩn đoán hình ảnh châu Âu, và từ năm 2010 bà là chủ tịch của Hội siêu âm tim quạt ngực trong Hội chẩn đoán hình ảnh châu Âu. Và Dr. Luna cũng được biết tới như một người tiên phong về siêu âm phổi trong các bệnh lý ví dụ như là suy tim, những bệnh nhân mà phải chạy thận, và những bệnh lý thấp khớp, và đặc biệt là những cái nhóm mà bệnh lý phổi. Đối với lại là trong hồi sức cấp cứu của chúng ta thì Dr. Luna cũng là một thành viên mà đã tham gia vào cái đồng thuận về siêu âm phổi năm 2012, người mà đã đặt nền móng cho cái vấn đề siêu âm phổi trong hồi sức cấp cứu được thực hiện. Và bà cũng được biết tới trong cái đại dịch COVID-19 này, bà được biết tới trong cùng là đồng tác giả nghiên cứu với lại là Dr. Von Piselli về cái vai trò của siêu âm phổi trong bệnh lý COVID-19. Và đối với lại là focus đối với Việt Nam thì chúng ta biết rằng từ năm 2014 thì bộ môn hồi sức cấp cứu và tôi đã mang speaker đầu tiên của hội với sự giúp đỡ của WinFocus Malaysia đến Việt Nam, và đã có những cái workshop sau đó, có rất nhiều workshop về cái vai trò của Focus trong cái hồi sức cấp cứu. Và hiện tại có rất nhiều bác sĩ của chúng ta đã làm được cái Focus một cách thành thạo ở tại giường. Và ngay cả trong cái đại dịch này, chúng tôi cũng đã tổ chức những cái khóa mà về cái online, cũng về webinar, cũng như là cái Focus Journal Club cho tất cả các thành viên của cộng đồng hồi sức cấp cứu Việt Nam để thực hiện cái, để học và để làm được cái siêu âm tại giường trong hồi sức cấp cứu này. Và sau đây tôi xin giới thiệu Dr. Luna Gargani sẽ bắt đầu cái bài về vai trò của siêu âm phổi trong hồi sức cấp cứu của chúng ta, bắt đầu từ những cái rất là cơ bản cho đến những cái ca lâm sàng trong COVID-19. Xin bắt đầu, xin mời.
Xin cảm ơn những lời chia sẻ của thạc sĩ bác sĩ Đỗ Hồng Anh. Sau đây sẽ đến phần trình bày về siêu âm phổi của tiến sĩ bác sĩ Luna Gargani. Quý vị lưu ý là trong suốt thời gian trình bày, nếu có câu hỏi cần thảo luận, quý bác sĩ vui lòng gõ vào phần khung chat bên phải màn hình như được thể hiện ở trên slide. Các câu hỏi sẽ không hiển thị cho tất cả các bác sĩ tham dự mà sẽ được gửi trực tiếp đến ban tổ chức. Cuối mỗi bài giảng, bác sĩ Hồng Anh sẽ tổng hợp lại và trao đổi với bác sĩ Luna Gargani trong phần thảo luận. Now we would like to introduce to you Dr. Luna Gargani, who will present lung ultrasound topic. Please give her our warm welcome.
Okay, thank you very much for the very nice introduction. So shall I share my screen now? Okay, good. So I'm very glad to be here today and have the chance to speak about the use of lung ultrasound in point-of-care echo and some features of why, when, and how to use it. And I hope I will be able to convey the message of how much lung ultrasound and more in general point-of-care echo can be really useful in our clinical practice. The scheme of our talk today, our about 90 minutes talk. But before we move to some lung ultrasound semiotics, I would like to make you understand what we are talking about when we say point-of-care echo. So point-of-care echo is some ultrasound that we do directly at the bedside of our patients. So it is an examination that it is not done by a radiologist. It is done by us, by the attending physician, the physician who is taking care of the patient. And somehow we can say that point-of-care echo is a kind of next generation physical examination, but actually it is not even next generation because it is something that is already ongoing and is helping a lot of physicians in their clinical practice. But it is a kind of super enhanced visual stethoscope that we can use with our patient. And to make you understand that this works, we have already quite a few papers and with very robust data to show how point-of-care ultrasound can be useful. So, for example, this study published already 6 years ago in the Lancet Respiratory Medicine compared two different strategies in patients coming to the emergency department with dyspnea, cough, or chest pain. So patients who were managed in a standard way, they had the correct diagnosis after 4 hours after admission to the emergency department in about 64% of patients. While those patients who were handled, who were managed, including to the standard diagnostic strategy, also point-of-care ultrasound. And since we are speaking of patients with respiratory symptoms, the point-of-care here was heart, lungs, and deep veins ultrasound. And in these patients, the correct diagnosis after 4 hours after admission to emergency department was in 88% of patients. So the main concept here is that we can do our diagnosis, of course, even without using echo. We have always done diagnosis without echo since now. But if you use point-of-care echo, you do your correct diagnosis much, much quicker. And this has been confirmed further in this very nice paper published in Chest in 2017. And it is on, as you can see, 2,000 and almost 700 patients. Again, these are patients coming to the emergency department with acute dyspnea. And in those patients where they were treated and managed in the standard way, the mean time to correct diagnosis was this one, so it was about 3 hours. And patients who were managed by using also point-of-care ultrasound, the mean time for a correct diagnosis was 24 minutes. So again, there is a huge saving of times to go to your correct diagnosis. So this is the main point why it is useful to use point-of-care echo. So let's see some basic semiotics of lung ultrasound. So this slide is quite important, and you will see it often during the presentation, because actually the concept of lung ultrasound is that it is a kind of densitometer on the lung. So by ultrasound, we can assess the aeration of the lung. So if we have a normally aerated lung, we actually don't see anything. We only see the pleural line moving with respiration, and we don't see anything else. But as far as the pulmonary air content decreases, because we have some pathologies in the lung, so we have a deaeration, we start seeing these signs, which are called B lines, and the less air we have in the lung, the more B lines we see. And when you are almost at the end of your pulmonary content, so when you have lost almost your pulmonary air content, you start seeing a consolidated lung. So until here, we have indirect images of the lung. So we have artifacts, but artifacts with a clinical relevance. And here we have the real image visualization of the lung with a consolidation. So let's start with the aerated lung, so the normal picture of the lung, and especially the pleural line. It is very important whenever you start an exam of lung ultrasound to check for the pleural line and to check for what we call the lung sliding. So the lung sliding is the regular depiction of the pleural movement during respiration. Okay, you can see indicated by the green arrow. And you have always to look for the lung sliding at first when you start your examination. Again, we have a lung sliding here with a convex probe and a lung sliding here with a cardiac probe. So this is the first check that you have to do when you start an exam. Then you may see still in an aerated or even over-aerated lung ultrasound cannot distinguish between aerated and over-aerated lung, can only see deaeration. Right? This is very important. So in a normally or over-aerated lung, you may see A lines. What are A lines? A lines are these lines here, horizontal lines here, indicated by the green arrows. They are reverberation of the pleural line. It's a normal finding. So if you see this kind of picture, it is normal. and the red arrow indicates the pleural line. You may see that all the A lines are at the same distance, and it is the distance between the surface of the probe and the pleural line. Here is another example of pleural line and A lines. So this is the pleural line with lung sliding, and this is an A line. And here you can also see what we usually call the bat sign in lung ultrasound. So these are the ribs and another rib, and the ribs make a shadow. And with a little bit of fantasy, you may resemble here a kind of bat, so the wings and the body of the bat. So this is the sign that we see when we put a probe in a longitudinal approach on the ribs, whereas when you put the probe transverse to the intercostal spaces, you don't see the bat sign, so you don't see the shadows of the ribs, but you see the lung sliding and the pleural line all the way without shadows. Okay, so we move on in our loss of air content, and we see the B lines. So the B lines are these hyperechoic vertical reverberation artifacts that start from the pleural line, and they are the sonographic sign of what we call the pulmonary interstitial syndrome, or we can also say they are the sonographic depiction of a partial deaeration of the lung. Okay. There are some features of B lines that can help to recognize them, but I can assure you that it is very, very easy to recognize B lines. So they arise from the pleural line, they move with the lung sliding, they are hyperechoic, so they're very bright, they are long until the end of the screen. Usually they erase A lines, at least in the point where they intersect, and they are well defined and laser ray-like. So some other images, examples of multiple B lines. This is with a cardiac probe, and this is with a convex probe. You can use actually any probe to do lung ultrasound. The convex probe is the most universal, but even a cardiac probe can see very well all the signs that we need. And the linear probe is more specific for a few things, but we will see this later. Okay, so B lines are a very non-specific sign. So we have said that they are the depiction of interstitial syndrome. They are the depiction of a partial deaeration of the lung. So we can see them in many different conditions, from cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, interstitial pneumonia, and also pulmonary fibrosis. And we will see how to distinguish them. Okay, and then we go on with the totally deaerated lung. So we have the lung consolidations, and actually you may have two main appearances of the lung consolidations. You may have a zone which is less echoic than the rest of the lung, like in this case. So this is the pleural line, this is the A line, and here the A line is interrupted by this less hypoic, more rough zone of the lung. Again, another example here, we have the pleural line, and it is interrupted by this less echoic appearance. But we can also have an appearance which is more, we call it tissue-like. So like in this example, this is the liver, this is the diaphragm, this is a tiny, tiny, small pleural effusion, and this is the lower lobe of the lung that is consolidated in a pneumonia. And also this is a very iconic example. This is the parietal pleura. This is the visceral pleura. There is quite a big pleural effusion, and the consolidated lung, which is floating into the pleural effusion. So when the lung has lost its air content, we actually directly visualize the pulmonary parenchyma, as it is a parenchymal organ, so the appearance is very similar to the liver or to the spleen. And we may use lung consolidations in many different clinical applications. For example, pneumonia, which is one of the most frequent. This is a pneumonia. This is a consolidation with the air bronchograminate. This is also a consolidation from pneumonia, and also a big basal consolidation here. But we may see consolidations also in pulmonary embolism if we have a pulmonary infarction. For example, this is a small pulmonary infarction and another one here. It's quite typical appearance of pulmonary infarction. But also if you have neoplasia. So for example, this is a cancer, a lung cancer, a primitive lung cancer. And with consolidations, we can call also the C lines. So C lines is a term that sometimes it is used. It is a bit less used than A lines and B lines, but when you see it written somewhere, now you will know what it is, because the C lines are actually these structures here, which has a kind of C appearance below the pleural line. So here we see the B lines, but we also see these subpleural hypoechoic zones that are called C lines. We usually call these subpleural alterations, and it is the same meaning, it's fine. So this was the first part about lung semiotics. If you have any questions, we have 5 minutes for question and answers now.
Okay, thank you, Dr. Luna Gargani for sharing your experience about lung ultrasound. Xin cảm ơn bác sĩ Luna Gargani đã chia sẻ các kinh nghiệm trong siêu âm phổi. Sau đây sẽ đến phần thảo luận cho chủ đề này. Xin mời bác sĩ Hồng Anh được chủ trì buổi thảo luận ạ. Em xin mời bác.
Tức là các bạn nếu mà có cái câu hỏi nào về phần các triệu chứng của phổi thì các bạn có thể text vào cái box chat. Mình sẽ collect cái câu hỏi của các bạn và sẽ hỏi Dr. Luna Gargani. Mình có 5 phút để cho cái trả lời cái phần đầu tiên này. Rồi, câu hỏi đầu tiên là có một bạn hỏi về what is the difference between the B line and Z line? According to Dr. Lichtenstein, he first table he said that the B line is a ring down as the core metal artifact, but right now many authors said the B line is a ring down artifact. And so what's the difference between the B line and Z line? So what is the mechanism of the B line and Z line and significance of each one? Thank you.
Okay, so this is a very complex question. First thing, difference between B lines and Z lines, if I have correctly understood. So I didn't put any slides on Z lines because we have a lot of information in this presentation and I wanted to put too much, but actually Z lines are some hyperechoic enhancement of the background of the screen, which may seem similar to B lines, especially to novice eyes, but they do not clearly start from the pleural line. They do not move with the lung sliding, they do not move with respiration, and they are very, very ill-defined. So B lines are very hyperechogenic, attached to the pleural line, moving rapidly with respiration. The Z lines are very blurred, hyperechoic enhancement of the background. And there is another issue very important for the differentiation, and it's that when you have Z lines, usually you have like 1 or 2. And even if you mistake them for B lines, if you have 1 or 2 B lines, this is not so clinically relevant, because when we look to B lines, they must be multiple to be pathological B lines. So there is, no really danger of making a clinically relevant mistake between the B lines and the Z lines. Maybe in the end, I will switch to another presentation and will show you some Z lines. And about the ring down artifact, there is a lot of ongoing discussion on whether the B lines are ring down artifacts or comet tail artifacts. And to tell the truth, there is not a final, sure answer for that. There are some physical experiments on the physical basis of B lines, but all of them are quite not so conclusive. But what we know from all the studies done by several labs is that we see B-lines when we have a partial deaeration of the lung. So whether it is strictly the interstitial edema or interstitial thickening of the lung, or whether it is something different, it is more alveolar, maybe this is not easily understandable by lung ultrasound, but surely they are always there when you have a partial deaeration, and less air you have, more B-lines you see. So it's more a clinical application than a complete understanding of the physical basis, which is something still ongoing.
Next question. What is the difference between the C line and Z line?
Okay, so they're very different. Actually, the Z lines, as I was saying before, are first of all vertical and very blurred, ill-defined, hyperechoic enhancement of the background, whereas the C lines are more horizontal and are those kind of semi-lunar C-shaped appearance that we have when we have subpleural alterations. So maybe if I can go back, so the C lines here, so actually this sign here is a C line, okay? So it's not vertical, it's horizontal, and it is C-shaped. So I mean, when we talk about semiotics, we have to say A, B, C, but to tell the truth, I usually don't like to call these C lines because I find it quite confusing, and your questions confirm that it can be a bit confusing. So we call these subpleural alterations, and that's it. Those are the C lines. But B lines, Z lines are vertical, C lines are not vertical. They are a kind of horizontal semilunar shape appearance.
Lung ultrasound terminology. Lung ultrasound, regarding to the lung ultrasound terminology, what's the difference between the peripheral and peripheral consolidation, subpleural consolidation, and C line?
Okay, they're all, I mean,
sorry.
So peripheral consolidation and subpleural consolidations are the same thing. Actually, it is maybe more correct to call them peripheral consolidations because all consolidations are subpleural, actually. So it's kind of redundant. We call them C lines when they are really, really small. And maybe they are not even a complete consolidation. They're a kind of alteration of the immediate subpleural space. Whereas when we speak about peripheral or subpleural consolidations, they are a bit bigger than that. I mean, they're more visible as a hypoechoic zone of consolidations. But they're, I mean, the physical basis for that is all the same, and it means that in that part of the lung there is less air than when you have the B lines. So you start to go to the very end of your pulmonary air content. You're almost without any air content in that zone.
Okay, the last one is the significance of C lines in diagnosis of the pulmonary embolism or pulmonary infarction.
Yes, so actually, again, when you have a C line, usually it is a very small alteration. If you want to be sure that what you are seeing is a pulmonary infarction, I would suggest to rely on a bigger peripheral consolidations, because sometimes a C line can also be present when you have some alterations of the pleural line, if you have a little bit of fibrosis of the lungs, so they're much less specific. So if you want to look for a pulmonary infarction, you need to see, even if it is small, but you need to see a whole consolidation, a peripheral consolidation, not only a blurred alteration of the pleural line, which are the C lines. I have some examples later, so maybe this will become clearer.
Thanks for the answer. So we will now continue.
Okay, great. So let's go on with the clinical applications of all the signs that we have seen. And we start again with the same scheme. And of course, we start with the aerated or over-aerated lung. And again, we start with the pleural line and the lung sliding. So the lung sliding is very useful because when you don't have it, it can be a sign of pneumothorax. So in this example here, you put a probe on an aerated lung, and what you see is the pleural line sliding. In this case, you put a probe here, you put the probe on a pneumothorax, and what you see is a pleural line which is not sliding. And please note that I've put this video, which is not so easy, on purpose because the video is moving, so you may think that this line is moving because the patient is very unwell. He's in pneumothorax, he's in respiratory dysfunction. But what you have to check for is the relative movement of the pleural line towards the upper layers. So here, the pleural line slides and moves against the upper layer. And here, the pleural line doesn't move compared to the upper layer. The whole picture moves, but the pleural line is not sliding. And if you are lucky enough to put your probe exactly in the point where the pneumothorax starts, you may see what we call the lung point, which is actually, we can consider it a pathognomonic sign of pneumothorax. So here you have the change between the absence of lung sliding and the lung sliding. So this point is the lung point, and it depicts exactly the point on the chest where your pneumothorax starts. So again, no lung sliding here, presence of lung sliding here. If you want to see the lung point very well, you may want to switch to a linear probe, to a vascular probe, but you can see it even with a convex probe and even with a cardiac probe. Okay, then let's see some consolidations, some examples of consolidations. And pneumonia, of course, is a kind of consolidations that we see more frequently in our patients. So there are some sonomorphologic patterns of pneumonia, and we have said that we may have this tissue-like appearance. So when you have quite a big consolidations, the appearance of the lung is very similar to the liver or the spleen, so it is similar to a solid parenchyma. And what you see inside are these hyperechoic stripes, which is the air bronchogram. So this is the air inside the bronchi, and it is visible as hyperechoic image. So this is quite typical of pneumonia. You see the tissue-like appearance and the air bronchogram in it. Then another quite typical feature of pneumonia is that it is quite blurred in its margin. So the margin of your consolidations are ill-defined, are very blurred. And again, you can see here some air bronchogram. And sometimes lung ultrasound can be very useful also to depict things inside your consolidation. So, for example, if you have a consolidation, and I know this one seems the liver, but this is actually a consolidated lung for a huge pneumonia. If you see a structure with a different hycogenicity in it, like this very rounded spherical structure here, you have to suspect that there is an abscess. So this is an abscess inside pneumonia, and you can see it very well with your probe. And of course, after this, you may want to move to HSCT, but you can have the first suspicion very clearly with your probe. And it is important to remind that what we see in adults can be seen also in child, and even in an easier way, because the children have a very small thorax, so it is even easier to see their lungs. For example, this is a child with a lobar pneumonia, and this is the appearance of the ultrasound of his consolidation. And this connection between adults and children is not only valid for consolidations, but you have to remember that all the signs of lung ultrasound that can be seen in the adults can be seen also in newborn, in neonates, and in children. We have to know the different disease because children and neonates may have different disease from adults, but the signs of partial deaeration, complete deaeration, consolidations, sibilance, and so on, and pneumothorax, everything, the lung semiotics is absolutely the same. So let's see other useful consolidations that we may find in our clinical practice. This is an image that, especially if you have heart failure patients, you may see quite frequently. So this is a very big pleural effusion, and this is the lung. This is a compression atelectasis. So this is when the lung has an effusion which is so big that can compress the pulmonary parenchyma. So the pulmonary parenchyma may be healthy, but it is compressed by the pleural effusion. And you can see that when the patient is breathing, the parenchyma is also enlarging again. And this is quite different from what we call obstructive atelectasis. So here we have the liver, here we have the diaphragm, and this one is a consolidation. But in this case, of course, it cannot be a compression atelectasis because you don't have pleural effusion. And if the consolidation is very similar to the genicity of the liver or the spleen, and you don't see a dynamic, a bronchogram, so you don't see the air moving inside the bronchi, it can be an obstructive atelectasis. Obstructive atelectasis is when your airways are blocked, so there is no more air inside moving, and this can be also suspected by ultrasound. And we were speaking about pulmonary infarction before. So the question was C lines or peripheral consolidation. A pulmonary infarction looks like this. So it is actually something more than a C line. A C line will be only a small alteration here of the subpleural space. This is much more of a real consolidation. And pulmonary infarctions are usually quite small. They are very often multiple and close one to each other, and they have a polygonal shape. So usually their margins are a bit more are not so blurred, are not so ill-defined as the pneumonia. But anyway, the differential diagnosis, of course, between pulmonary infarction and pneumonia is not done only on the basis of lung ultrasound. You have all the clinical appearance, but sometimes also the consolidations can be very different between them. Okay, and now we are at the B lines. So the B lines have a lot of clinical applications because we said that they are the sign of a partial deaeration of the lung. So partial deaeration of the lung can be present in many different conditions. So we span from heart failure to patients with dialysis, patients with acute respiratory distress syndrome, pulmonary fibrosis. That can be also used in other situations like in pregnant women with preeclampsia. So let's start with the main application of B lines and the first application of B lines, which is cardiogenic pulmonary edema, and in particular they have been used in patients with acute dyspnea to differentiate between COPD exacerbation and acute heart failure. So if you have a patient with acute dyspnea with COPD exacerbation, actually you don't see multiple B lines. You may have a picture of an absolutely normal lung. As we have said in the beginning, the normal aeration or the over aeration that you have with COPD is the same as lung ultrasound. So you see a kind of normal lung ultrasound pattern. You have the lung sliding, you have A line, A line, A line, but no B lines. In cardiogenic pulmonary edema, you see many B lines. And it is important to remind that when you look for B lines in acute heart failure, the B lines needs some adjectives. So you cannot only say there are B lines. B lines must be multiple. It means that in one video, in one scanning site, you must see many B lines. They must be diffuse. It means that you must see B lines in more spots over the chest, and they must be bilateral. This is the typical picture of acute heart failure. And this is important because sometimes, even in COPD exacerbation, you may see a few B lines. For example, here you have a few B lines at the base of the right lung, but these are not multiple, these are not diffuse, and these are not bilateral. So these are not pathological B lines, okay? This is quite important to know because the first times you use lung ultrasound, you may misunderstand the meaning of B lines. So B lines must be pathological, multiple, diffuse, bilateral. And now B lines have entered also recommendations paper. And for example, in the flowchart of suspected acute heart failure, in the diagnostic test, you find echo of the lung and the heart. And this is 2015, so it's already 5 years that we have this advice in our recommendation for suspected acute heart failure. And to make you understand again how it is clinically relevant, there is a very beautiful study published last year studying patients arriving to the emergency department with acute dyspnea as the main symptoms, and so patients with a suspicion of acute heart failure. And patients were randomized between patients with a standard management using chest X-ray and NT-proBNP to diagnose or exclude acute heart failure, and patients who were studied by lung ultrasound. And what happened again is that the patients that were studied by the standard approach, so chest X-ray and NT-proBNP, the time needed for a correct diagnosis was almost 2 hours, 1 hour and a half. The patients who were approached with lung ultrasound, the mean time, the median time to formulate the correct diagnosis was 5 minutes. So actually there is a huge, again, save of times if you use lung ultrasound for the differential diagnosis of acute dyspnea. And I think there is another situation where a lung ultrasound can be really useful in, especially for cardiologists and people in the emergency departments, and it is with heart failure with preserved ejection fraction. And because you may see patients with apparently normal heart, yes, the diastolic function can be impaired, but sometimes it is not so easy to assess well the diastolic function. But if in a patient with dyspnea and that kind of heart, you see the multiple diffuse bilateral B lines and maybe trivial pleural effusion in the right costophrenic angle. You see this is a liver, diaphragm, very small pleural effusion. This is a costophrenic angle, and the lung coming with the respiration. So in this case, your clinical suspicion of heart failure with preserved ejection fraction, and this is the clinical details of these patients, can be very quickly reassured. So maybe you see these patients in your ambulatory office, you may suspect the patient has heart failure with preserved ejection fraction, but usually you will send the patient to have natriuretic peptides lab, or you would send the patient to have a chest X-ray. In this case, in your ambulatory office, you can combine heart and lung ultrasound and confirm your clinical suspicion soon and start your therapy soon. So lung ultrasound is a very ideal tool for monitoring. So we have spoken about diagnosis, but it is really useful also for monitoring because you can do it bedside. It is relatively low cost, doesn't use ionizing radiation, so you can use it many times, and it is very dynamic. So it's perfect to do what we call a clinical ultrasound, so an ultrasound which is done directly at the bedside of the patient. And very quickly, to show you some evidence for that, still in heart failure patient, if you check and you monitor the pulmonary congestion with lung ultrasound in your heart failure patients who are hospitalized, your discharge time actually is lower than if you use chest X-ray to monitor the pulmonary congestion. And again, in patients hospitalized with acute heart failure, those who are lung ultrasound responders, so patients who have a significant decrease of B lines, have a much better survival compared to patients who are non-responders. So again, you can monitor your patients during hospitalization for acute heart failure, and if your patient doesn't decrease the number of belines, you know that this patient will have a higher mortality and a higher a chance of being re-hospitalized for acute heart failure. And in the end, the real utility of using lung ultrasound in these patients is that you can differentiate what we call a hemodynamic from pulmonary congestion. Why? Because hemodynamic congestion is the increase of pulmonary pressure, is the increase of left ventricular pressures, but this is different from having the real pulmonary congestion, which is the presence of extravascular lung water. So you may have two patients with heart failure with the same ejection fraction, very similar pulmonary capillary wedge pressure, very similar pulmonary artery systolic pressure, so very similar hemodynamic congestion. But one patient may have extravascular lung water, and you see the belines, and another patient can have no extravascular lung water or very few extravascular lung water, so no belines. And actually what you can do with your probe is a kind of a Forrester scheme. So we know that in acute myocardial infarction, you can assess congestion and perfusion by the Swan-Ganz. You can do it also with a physical examination, but it's quite non-specific and not sensible. If you do it with your probe, you can assess both congestion with the lung ultrasound and perfusion, for example, with a TVI of the left ventricular outflow tract, and you may have an idea if your patient is dry and warm, wet and warm, dry and cold, or wet and cold. So you can use your probe as a kind of non-invasive Swan-Ganz catheter. And again, in patients with acute heart failure, belines are very useful because if you do a lung ultrasound the days of discharge, those patients who go home with a few belines, they do not come back in the next 3 months for a new hospitalization. Whereas all the patients in our population who came back after 3 months for a new hospitalizations, they all had a lot of belines on the day of discharge. And this is the same also in ambulatory office patients. It is actually the same Kaplan-Meier here. So if you have a lot of belines during an ambulatory office visits, your survival and incidence of readmission for heart failure is worse. And there is also a trial with lung ultrasound guided treatment for patients with heart failure. So patients that go to the ambulatory office with chronic heart failure, and if you check them, you monitor them and change your diuretic therapy also according to the lung ultrasound, not only on the lung ultrasound, but also you integrate the lung ultrasound with all the rest of your tools, actually these patients has a better outcome and they have less urgent visits for worsening of heart failure. And this is another study with actually the same exact results. So if you adjust your diuretic therapy on lung ultrasound of your patients, you have a less incidence of urgent visits for heart failure, re-hospitalization for acute heart failure, and death. So this is a very recent paper. So maybe we can say that in a very next future, belines will guide us in the therapy, in the treatment of heart failure. The old name of belines was ultrasound lung comets, so we did this small wording game here that the comets will guide us somehow in deciding the diuretic therapy of these patients. So very quickly, dialysis patients, you can use the belines to assess the pulmonary congestion, and even here again, you have a strong prognostic relevance of the presence of belines in patients on dialysis. So the more belines you have in the interdialytic period, the worst outcome you have. And ARDS, this is very important. So ARDS is actually another pulmonary edema. So you see the belines as you see them in a cardiogenic pulmonary edema. But there are quite some different features. And for example, you have both in both situations you have B-lines, you have multiple diffuse bilateral B-lines, but the pleural line in cardiogenic pulmonary edema is usually very regular and thin, whereas in ARDS you may have what, again, our subpleural alterations. So we can call these C-lines if we want. These are very typical C-lines. So this appearance is much more typical for an inflammatory edema, non-cardiogenic edema, whereas cardiogenic edema has a very regular and thin pleural line. And there are some other features that can help you to distinguish by the lung ultrasound the cardiogenic from the non-cardiogenic edema. Of course, again, you don't do this differential diagnosis based only on lung ultrasound, but this can be very useful to help you to support your diagnosis. And what we can do is for monitoring patients, especially critically ill patients, is applying a lung ultrasound score. So we can give a point of 0 for a normal lung with A lines. We can give a point of 1 when you have multiple B lines, but still separated. Usually we consider less than 50% of the screen with B lines as number 1. You can give a number 2 when you have multiple coalescent B lines, and give a number 3 when you have a lung consolidations. And you can give the number on each of the region of the chest. And with this score, so actually 0, 1, 2, 3, you can monitor your patients. And not only, this score has been used, for example, to suggest the correct timing of weaning. So if you have a patient and you have to decide when to extubate the patient, in general, if you have a very high lung ultrasound score, it means that you have a very deaerated lung. So it is much less likely that you can extubate your patient. It is clearly seen here. So if you have less than 13 as a lung ultrasound score, you can extubate your patient with a quite high success rate, with a very low post-extubation distress percentage. If you have a higher number of lung ultrasound score, your failure with extubation is higher, and you have more post-extubation distress. So again, the general concept is that if you have a low lung ultrasound score, you have less deaeration, so you have an increased likelihood of success extubation. If you have a high lung ultrasound score, you have an increased likelihood of failure of extubation. And of course, there is also a gray zone. So this is the way some intensivists can use lung ultrasound to manage their patient. And for the weaning, it's important that if you are very good with your probe, don't consider only the lung, but also consider the heart and the diaphragm. I've just put a few slides on the ultrasound of the diaphragm. It is very easy to be done. You put your probe here, and this is the position, and actually you put the M mode, and you see your diaphragm contracting and moving when it works fine. When it doesn't work, you don't see it going up and down, but you see paradoxical inward of the line of the diaphragm. We don't have time to go deeply into this, but just to give an idea that you can insonate many different organs. And with the same principle, you can use lung ultrasound also to assess the risk of overdistension. So, for example, if you have a patient in mechanical ventilation and the patient has a lot of A lines, it means that your lung is quite aerated. Your risk of overdistension is higher because you're already ventilating an aerated lung. On the other hand, if you have a lot of B lines, your risk of overdistension is a bit smaller because your lung is much more deaerated. And of course, again, you don't use only the lung ultrasound to decide the PEEP to apply to your patient on mechanical ventilation, but it can help you integrate it with all the other parameters to better decide how to adjust and titrate your PEEP and other indices during mechanical ventilation. Okay, so just very quickly, I will show you also how B lines look like in pulmonary fibrosis. We know that B lines are not specific. You can see them in all interstitial conditions. But in pulmonary fibrosis, again, you have a very alterated pleural line here, okay? So it is not the thin regular pleural line that you see in acute heart failure. And pleural effusion, we usually did a lot of ultrasound for pleural effusion. I mean, this was the first part of the thoracic ultrasound that was there. Then we had the parenchymal ultrasound, which was a kind of revolution, but we don't have to forget that pleural effusion is still full of information for us. And again, we cannot do a differential diagnosis of the etiology of pleural effusion basing only on ultrasound. But your ultrasound appearance can really help you with that. So for example, this is a quite typical appearance for heart failure. You have an anechoic pleural effusion. You may have the compression atelectasis of the lung here and here. But if you see this kind of effusions, which are very corpusculated, very they seem full of things inside, they're not likely at all to be heart failure. Or if you see all these fibrin strands in your pleural effusion, again, this is very not typical of acute heart failure. And indeed, this is a hemothorax, and this is a pleural effusion with malignancy. So anytime you see fibrin strands, anytime you see a very corpusculated pleural effusion, which is what we call a complex pleural effusion, you have to think that heart failure is very unlikely, or at least you may have heart failure, but also something else in your patient. And in the end, the big help of lung ultrasound in general is that if you have a chest X-ray and you have a radiopacity, that radiopacity can be pleural effusion, can be consolidation, can be huge pulmonary congestion. And it's quite hard to tell on a chest X-ray what is pleural effusion or consolidation or congestion. But with lung ultrasound, it is quite different. So here the radiopacity is a consolidation. Here the radiopacity is mostly a pleural effusion with compression atelectasis. And also the diagnosis of the patient is different. So it's much easier than with your chest X-ray because you can understand what a radiopacity is. Okay, so we have seen many things. We have some more question and answer time now.
Okay, thank you, Dr. Gargani, for sharing lots of knowledge about clinical application of lung ultrasound. Xin cảm ơn bác sĩ Gargani đã chia sẻ nhiều kiến thức hữu ích về ứng dụng lâm sàng trong siêu âm phổi. Xin mời bác sĩ Hồng Anh chủ trì tiếp buổi thảo luận và đưa ra các câu hỏi cho bác sĩ Gargani ạ.
Có một câu hỏi là one question from the audience. Do you use the focus to diagnosis pulmonary embolism?
Yes, and I have a few slides dedicated on that in the next few minutes, so I would postpone the answer to those slides if I can, yeah. But yes, we can.
So can you move on to the topic, lung ultrasound in COVID-19?
Okay, very well.
And
so
then we have a question and answer. Okay.
Good. Yes, so unfortunately this is very actual, up-to-date issue now. So lung ultrasound has received a huge increase in interest with the coronavirus because we know that the pulmonary involvement that we have in COVID-19 can be easily seen by lung ultrasound. So let's see a few technical features that can be applied also to general lung ultrasound, but are even more important in COVID. So preset. Many machines have a lung preset now. If you don't have a lung preset in your machine, you can use the abdominal preset. And you have to scan for at least one complete respiratory cycle to be able to see the lung sliding very well. Then the depth, this is important in all lung ultrasound, but even more in COVID. You should go, if you have a convex probe, at about 8-10 centimeters. If you have very lean patients, you may go lower, 6-8. If you have higher, more obese, overweight patients, you may want to increase your depth to 10, 12, and even more centimeters. Then the gain, you have to adjust the gain to optimize the visualization of the pleural line. So this is the zone that you have to look for when you optimize your gain. And also the focus, it would be nice to put the focus on the pleural line. You can do lung ultrasound even without adjusting the focus, but you can see much better the subpleural alterations and all the C lines and peripheral consolidations and so on. Okay, so the scheme. There is not a universally accepted scheme for COVID, for lung ultrasound in COVID, but actually this is the most used scheme among different labs. And actually it is the same scheme that we have seen for acute respiratory distress syndrome. So you have anterior chest, lateral chest, and posterolateral chest. And all these regions are divided in upper and lower. So upper anterior, upper lateral, lower lateral, upper posterolateral, lower posterolateral. When I say posterolateral, it means actually these zones. So even if your patient is intubated, you can scan the patient by rotating, by tilting the patient a little bit. But if your patient can sit, and if you want to scan the back very clearly, you can ask the patient to sit, and you can easily scan also the back. So what to look for in COVID-19? Actually, we can see all the different signs of lung ultrasound here, starting from the B lines. And here I will show you some videos of COVID patients. So you may find separated B lines, as in this case. You see pleural line be sliding, B lines, and the A lines here. And this is the Z lines. So we were speaking about what is a Z line. This one is a Z line. So it doesn't move with respiration. It is much more ill-defined. It's different from the B lines here. B lines here, Z line here, okay? But you can also have coalescent B lines. So B lines that are all attached one to the other, as in this case. They're not separated, they're not coalescent. And when you have these very coalescent B lines, you may have what has been called in COVID-19 the light beam. So the light beam is a kind of band of coalescent B lines, very hyperechoic and with a very clear distinction between the part of B lines and the rest of the lung. I will show you the other examples. So there is a light beam here, actually a band of very coalescent B lines. Another example here, this is the light beam. And again, you can see that the difference between diseased lung with light beam and the rest of the lung is quite abrupt. So we pass from completely abnormal to completely normal very clearly. And it is different from cardiogenic pulmonary edema. Cardiogenic pulmonary edema is much more uniform. This is what we also call a spared area, very normal lung attached to a very abnormal lung. Another light beam example, again, very abnormal, close to very normal here. Then we can see an irregular aspect of the pleural line, the C lines. So this could be called a C line here because it is a irregular appearance, but it's not really a consolidation. So you have the B lines and you have an irregular appearance of the pleural line. Again here, a lot of B lines and irregular appearance of the pleural line. And you could call these C lines. But you may also have more clear peripheral consolidations. We have now learned that peripheral is even better than subpleural because all of them must be subpleural. So you have the B-lines and you have those small peripheral consolidations. Okay, and here again, a more defined peripheral consolidation. You can see it and a lot of B-lines. You may also have a large consolidation, but this is a bit less common, and usually you see large consolidations in very advanced cases. So usually cases that are in the ICU and need ventilation. And the same is for pleural effusion. A large pleural effusion is quite uncommon in COVID-19. You may find it, but it is not so common. It is much more common to find a trivial pleural effusion, as in this case you have the parietal pleura here, and you have a small, tiny pleural effusion before you see your deaerated lung. And again, you may use your score, the score that we have seen before, 0, 1, 2, 3, and you can apply it from 0 to 3 to the scheme that we have seen before. And in this way, you can have also a quantitative information about your lung, not only a qualitative information. And you can also monitor your patient in an easier way. But don't consider only the degree of the aeration, because the distribution and the kind of lesions you have is very important. So, for example, if you have a lung ultrasound score of 10, it is different if it comes from 2 large consolidations that may give 3 + 3 point, or if you have 10 of lung ultrasound score because you have 5 spots in your lung with a score 2, or if you have 10 spots in your lung with score 1. So you have to consider both the deaeration score, but also the qualitative pattern that you have in the lung and the distribution. The most frequent part of the chest where you find alterations in COVID-19 is the posterior chest, especially in the beginning. So for the diagnosis, you always have to scan also the posterior chest. Otherwise, you risk to miss the alterations. So this is quite important to remember. And to give you an idea of all these alterations together, this is a patient who went to the hospital for dyspnea and fever. It was the 17th on March. So this was his CT, and you can see a lot of B-lines, both separated and coalescent B-lines. We start having here a small peripheral consolidation. So this is a clear pulmonary involvement, not so bad, but clearly there is something going on here, both on the lung ultrasound and the CT. And after a few days, the patient deteriorated a lot and needed access to the ICU. And you can see that the lung ultrasound has worsened. So we pass from the B-lines to having here B-lines, but also consolidations. You can see this is a quite big consolidation. Also here we have a consolidation, and here we're starting having a consolidation as well. And here as well. And this was the CT corresponding to this lung ultrasound picture. So actually, it is a very useful tool to monitor your patient. It cannot completely replace the chest CT, of course, but whenever you cannot bring a patient to do the chest CT, and in COVID patient, this is very sensitive issue because, of course, moving a patient is always an issue, and also for the risk of spreading the infection, you can go bedside with your ultrasound machine, and you can see that there are changes, and if the deaeration of the lung is worsening, actually. And when you can use lung ultrasound in COVID-19 patients, actually there are many clinical scenarios, both home, for example. In Italy, there are a lot of places where there is a service, and if you are a patient with COVID-19 and even if you are suspected to have it because you have symptoms, or if you have already a diagnosis, but we don't know if you have a pulmonary involvement, people come to your house with an ultrasound probe and do a lung ultrasound. So in this way, we avoid the patient to go to the hospital again, so you reduce the risk of spreading the infection. Of course, you can use it in the emergency department, especially for diagnosis, but you can use it in internal medicine, infective disease ward, pulmonary ward, I mean, all the hospital wards where these patients can be admitted, and this for monitoring, as we were saying, and also for risk stratification, and sometimes also to monitor treatment response. And the same in intensive care unit, you can try to use it for monitoring and titrate your mechanical ventilation there. And for the diagnosis, actually, lung ultrasound is quite useful. So when I was saying you go home to a patient who has acute dyspnea, you don't want the patient to come to the hospital. And if you have lung ultrasound, not only you can see if there is a pulmonary involvement, but sometimes you may also do a differential diagnosis with other conditions that can give you acute dyspnea. So for example, the patient has acute heart failure or has a bacterial pneumonia, so no COVID, you can see it with lung ultrasound. So it's not only useful to rule in COVID-19 pulmonary involvement, but also to better understand the cause of the acute dyspnea in case there is another etiology. So to make a clinical integration, again, in the diagnosis, just to show you that whatever we are saying is grounded on data, there is this very, very recent paper published a few days ago, actually. It is still in the pre-proof version, and you can see that in patients with suspected COVID-19, if you use only the clinical evaluation, your sensitivity and specificity are this, and they can be significantly increased if you add to the clinical evaluation also the lung ultrasound. And of course, this is a sensitivity and specificity of the swab of the PCR tampon that we use. And a lung ultrasound is also useful for prognosis in these patients, because if we go back to the concept of the score, if you have a lower lung ultrasound score, you have a better survival and better outcome in terms of need of mechanical ventilations. So here we divide patients in patients with a lung ultrasound score less than 18 and more than 18. Patients with more than 18 of lung ultrasound score die more and need more mechanical ventilation. So it is actually useful for the risk stratification of patients. So to summarize, in COVID-19, we still don't have no clear cutoffs and no clear flowcharts, but we start having some studies to help with this, can have a role in diagnosis because it is more sensitive and portable of chest X-ray. And we can rely on the very high negative predictive value and very high sensitivity. It has a role in risk stratification and short-term prognosis, both for mortality and need of mechanical ventilation. And there can be a role in monitoring and titrating treatment, both for drugs, respiratory support, and time of weaning. But it's very important always to integrate all these lung ultrasound signs with the overall picture, of course, and the other tests. And also, don't forget to consider the distance from symptoms and your lung ultrasound exams, because the sensitivity of your lung ultrasound exam is very related to the distance from symptoms onset. And some pitfalls to take into account: lung ultrasound for COVID-19 is not really a lung ultrasound for novice sonographers, so it takes a little bit of experience to do it well, especially because the pattern is very patchy, and again, usually it starts at the back, so you have to scan all chest. It is different from, for example, acute heart failure, which is very easy to be seen with lung ultrasound. Even someone who has never done any ultrasound in his or her life can do that. Here it's a bit more difficult, but not so much. And of course, even with ultrasound, you have some risk of spreading the infection, so you have to follow the instructions for cleaning your machine and do the exam only if you think that the results can impact the management. And so very quickly we move on to the last part of the presentation. So we see how to integrate lung ultrasound as part of the point of care approach. And I would like to show you this very beautiful study done in patients with undifferentiated hypotension, so patients with shock or hypotension, we don't know the cause. If you integrate a point of care ultrasound approach, this can be very helpful to understand the etiology of your hypotension. So, for example, if you look at the heart, you don't have to do a complete echocardiogram. You just have to see whether the heart is hyperkinetic or if the heart is severely impaired or if you have a huge pericardial effusion. So very simple things. This is point of care focused echo. You can give a look to the inferior vena cava and consider only big extreme changes. So if your vena cava is very small or if your vena cava is very big. Of course, you can see the lungs, if you have the B lines or not, or if you have consolidations. And you can also give a look to the abdomen if you see some ascites, so if you see free fluids in the abdomen. And you can check the peripheral veins for deep vein thrombosis. So let's see how to integrate all of these together. And of course, this can help you to distinguish hypovolemic, distributive, obstructive causes of hypotension, and also, of course, cardiogenic. So let's see some examples. You have these patients. The clinical scenario is always you have a patient with respiratory failure and circulatory failure. So a patient with really acute dyspnea and significant hypotension. What is the cause? So you give a look to the heart. You see a very hyperkinetic heart moving very fast. You go and see the lungs, and actually you don't see anything particularly striking. You see the lung sliding, you see the A lines. Maybe there is just one B line here coming, but one B line, we know it's not pathological. The inferior vena cava is quite small. So your clinical suspicion may be that this is a hypovolemic shock, okay? And if you're lucky enough maybe to play with your probe, you may also visualize a large abdominal aorta aneurysm that can be dissected. Of course, this is not the only cause of hypovolemic shock, but this is a cause where you don't only see the heart and the lung response to the hypovolemic shock, but you can also visualize the real cause of your hypovolemic shock, because you can visualize with your probe the section of the abdominal aneurysm, abdominal aorta. So another example, still same kind of clinical pictures, a patient in severe respiratory and circulatory failure. You see the heart. The heart is moving fast, but is not contracting very well. We can say there is a severe reduction of left ventricular ejection fraction. You move to the lungs, you see multiple B lines. Of course, you need to see multiple diffuse bilateral B lines. I mean, even here, it would be quite fine for me for having a very strong clinical suspicion. You may want to check also the inferior vena cava if you want. You have a large collapsing vena cava. So this is very highly suspicion of cardiogenic shock, okay? So you have pulmonary edema, a non-moving left ventricle, and a big plethoric inferior vena cava. Another example, same picture, respiratory and circulatory failure. You go with the heart and you see there is some mass here moving. Or you start with your lung and you see a big consolidation. So both of these cases, of course, these are two different patients. This is a patient with endocarditis. This is a patient with a big pneumonia. But if this patient is in shock, you can suspect a distributive shock for sepsis, because you are able to see the cause of the sepsis. Can be in the heart, the endocarditis, or can be in the lung if you have a large pneumonia. And again, very important here, you have to consider what we call the focal interstitial syndrome. So sometimes if you have a patient with some multiple B-lines but not diffuse, so the B-lines are found only in a spot of the chest and the rest of the lung seems normal, consider that these focal multiple B-lines can be the first sign, a red flag for a consolidation that is going to develop quite soon. This is myself. I had pneumonia a couple of years ago. I had fever and chest pain, so I put a probe on the place of chest pain and I saw these B-lines. The rest of the chest was normal, and after a few hours later, in the same spot of the B-lines, I had the consolidation of pneumonia. So the B-lines here can be the first part of the deaeration path going towards consolidation, or can also be the perilesional edema that you may have with consolidation. So when you see this focal interstitial syndrome, don't think this is normal, but suspect that there is a consolidation going on. And going back to our patients with respiratory and circulatory failure, we see this. So we see large pericardial effusion, but especially independently of the dimension of the pericardial effusion, we see that the right ventricle is collapsing here. Lung, nothing interesting in the lung, A lines, no B lines. This is very likely an obstructive shock due to cardiac tamponade. Or if you see this patient, you see a patient from the subcostal view with a large right ventricle, you may already suspect that this patient has what? Pulmonary embolism. But if you also see the small pulmonary infarction, and especially you can also go and check the veins and see the deep vein thrombosis, you can do a very nice diagnosis of obstructive shock due to pulmonary embolism. And to answer the question before, can we use POCUS in pulmonary embolism? Yes, you have to check the heart, the lung and the deep veins, and there is this very nice study showing that if you do heart, lung and vein alone, your specificity is very high, but the sensitivity is quite low. But if you do your multi-organ ultrasound, point of care multi-organ, combining heart, lung and vein, your sensitivity significantly increase. Okay, this must be patient with a significant pulmonary embolism, a hemodynamically relevant pulmonary embolism. Otherwise, echocardiography is not going to show you much. But if you have a circulatory failure due to pulmonary embolism, it means that your right ventricle is enlarged and doesn't work properly. Some limitations to this approach, of course, you can have sometimes mixed conditions for circulatory failure, and sometimes you may have, for example, other causes of infection that cannot be seen by ultrasound. So if you have a pneumonia, okay, you see it, but if you have a sepsis due, for example, to a urinary infections, you cannot actually see it by ultrasound. And you can even combine all these in a kind of flow chart. This is from Daniel Lichtenstein. Very quickly, it is the same approach, but put in a nice order. You have a patient in circulatory shock, circulatory failure. You check for pneumothorax on the lung. So first you put the probe on the lung. Then if you don't see anything, you put the probe on your deep veins to search for a thrombosis caused for pulmonary embolism. Then you go to the subcostal view and you see the heart and inferior vena cava, and in case you see a large pericardial effusion. And then you move to parasternal or apical view of the heart to see if there is a tamponade. So a very step-by-step approach. There is another flowchart here, but it is very similar. Again, you have a patient in circulatory failure. First thing, you watch to the lung and you can exclude that there is a pneumothorax. You search for the subcostal view, and you can exclude that there is a tamponade if you don't see a pericardial effusion, or a pulmonary embolism if you don't see a very dilated right ventricle. And so here you already exclude two causes of obstructive shock. If you see the B profile, so if you see multiple B lines, probably you may have cardiogenic shock. If you don't have the B lines, you can suspect either hypovolemic or a septic shock. So, of course, you need to go a little more deeper in this, but it is a very simple, logical, step-by-step approach on how to use multi-organ point-of-care lung ultrasound in very critically ill patients. Very quickly, some limitations. Of course, we are speaking about ultrasound, so there is some operator dependency. In very obese patients, sometimes lung ultrasound is difficult, but only in severe obesity. If you have a subcutaneous emphysema, you cannot do lung ultrasound because you have air between your probe and the lung. And if you have a patient with a lot of bands, pads, drainage, sometimes it's difficult even to find the place of the thorax where to put a probe, but you can always try to find something more. And remember that these signs are not specific, but this is the same for chest X-ray, this is the same for chest CT. But if you monitor your patient, if you use a multi-organ approach, and especially if you do a strong clinical integration, the specificity will much more increase. So what is this again? This is the clinical ultrasound. You do it bedside. It is done by the attending physician to answer a specific clinical question. It is very dynamic. You can monitor patients. It is better if you do it multi-organ, so not only the lung, but also the heart, the abdomen, the veins, only small things for each organs, and need a strong clinical integration. So we have come back to the first things we were saying. This is a clinical ultrasound. This is an extension of our stethoscope. So actually we are moving toward this, an integrated multi-organ ultrasound approach, which we have seen can really help us to better diagnose, better monitor, and better cure our patients. So this was my last slide, and we have still a bit more time for question and answers.
Yeah, thank you. Thank Dr. Luna Gargani very much for bringing the most concerned topic to Vietnamese doctor. Trân trọng cảm ơn bác sĩ Luna Gargani đã đem đến cho mọi người một chủ đề đang rất là quan tâm. Giờ đã đến thời gian cho buổi thảo luận về siêu âm chẩn đoán viêm phổi trong COVID-19 và các ca lâm sàng siêu âm phổi trong hồi sức cấp cứu. Xin mời bác sĩ Hồng Anh chia sẻ các câu hỏi của các bác sĩ tham dự để trao đổi với lại bác sĩ Gargani ạ.
Mình sẽ trả lời bằng tiếng Việt cho cái câu hỏi lần trước của bạn. Có một bạn hỏi là cái vai trò của focus trong chẩn đoán của thuyên tắc phổi. I'm sorry, Dr. Gargani, I will explain in Vietnamese for the last question. The role of the focus in diagnosis of the pulmonary embolism for the Vietnamese audience. So, vừa rồi cô ấy có nói rằng là có thể dùng focus để chẩn đoán thuyên tắc phổi, là theo cái nghiên cứu của tác giả Nigerian thì người ta khi người ta kết hợp là siêu âm tim, siêu âm phổi và siêu âm tĩnh mạch thì người ta có thể tăng cái độ nhạy của chẩn đoán thuyên tắc phổi lên đến 90% so với lại là siêu âm riêng lẻ từng cơ quan một. Thứ hai nữa là cái câu hỏi của bạn là cái protocol nào sử dụng, thì người ta có thể có hai cái protocol ở đây. Thứ nhất là cái protocol Sesame của tác giả Liechtenstein và cái protocol trong bệnh nhân mà bị ngừng tim. Trường hợp thứ hai là trong cái bệnh nhân mà bị shock thì là người ta sẽ sử dụng cái phone protocol mà cô ấy vừa giới thiệu. Cái này các bạn có thể search ở trên internet, nếu các bạn đánh hai chữ là Sesame protocol và phone protocol, các bạn có thể tìm thấy trên cái Google search một cách rất là đơn giản. Đó là câu hỏi của bạn cho cái chẩn đoán thuyên tắc phổi. Còn có một câu hỏi là so Dr. Gargani, so the audience have did not understand what you explained about the subpleural consolidation and pulmonary embolism. So can you make more clearer differences?
Yeah, sure. So actually, if you have a patient with pulmonary embolism, what can you see with your lung ultrasound? You may see the pulmonary infarction, okay? I have to say that in case you don't have yet a pulmonary infarction, you don't see anything. So lung ultrasound in a suspicion of pulmonary embolism either doesn't show anything, or it can show the pulmonary infarction, or even it can show the focal interstitial edema in the very, very early stages. What I was telling before about the focal interstitial edema, which is localized multiple B-lines, focal B-lines, that can be the red flag for a consolidation, which is going to develop a little later, is valid for all kinds of consolidation. So not only pneumonia, but also pulmonary infarction. So again, you have a patient with pulmonary embolism. You may not see anything by lung ultrasound, so you may see an aerated lung in case the pulmonary infarction is not yet developed, or maybe you cannot assess it, or you can see the consolidations of the pulmonary infarction, which if we compare this to pneumonia, for example, pulmonary infarction consolidations tend to be smaller. Often there are multiple. For example, here we see actually two in the same video. The margins, the borders are more defined, are not blurred and ill-defined as in pneumonia. These consolidations are more polygonal, triangular, more rectangular. I mean, they have a polygonal shape and more defined, better defined margins. So this is quite typical for small pulmonary infarctions in pulmonary embolism. But again, these pictures here, you have always to consider the clinical presentation, because also for the heart, this is very important. If you have a patient in circulatory failure, so a patient in shock or severe hypotension, if the hypotension is due to the pulmonary embolism, you have to see a very dilated and dysfunctional right heart. Otherwise, the hemodynamic basis for your hypotension and shock, where is it? Okay? But if you have a smaller pulmonary embolism with a patient with only some dyspnea, you may not have this in the heart, but you may still see the pulmonary infarctions. And another suggestion is that if you have a patient with chest pain, which may happen in pulmonary embolism, you have to check first in the place of the thorax where the patient says there is chest pain. For example, the patient says, I have chest pain here. So go and check with your probe, because if the chest pain is a pleuritic chest pain, and if you have a peripheral consolidation, of course you have a pleuritic pain because the consolidation touches the pleural line, you have to see it with your probe. There is no way you miss it because it is peripheral. If it touches the pleural line and gives you pain, it is peripheral. You can see it by ultrasound. So if you're lucky enough that your patient with pulmonary embolism has chest pain, check at first where the patient says there is chest pain on the thorax.
So I can explain in Vietnamese for the audience this question. So các bạn, tôi tóm tắt lại cái câu trả lời của Dr. Luna là như thế này. Các bạn muốn chẩn đoán phân biệt giữa là cái hình ảnh mà pulmonary, thực ra là pulmonary infarction thì rõ hơn ở câu hỏi của bạn là pulmonary embolism, bởi vì infarction thì cái size của nó sẽ nhỏ hơn so với lại pulmonary embolism. Thì cái sự khác nhau đó là các bạn thấy nhìn là nếu mà pulmonary infarction thì là cái hình đó nó sẽ là một là hình tam giác, hai là hình chữ C ạ. Và cái hình nó rất là đều, bờ nó rất là đều chứ nó không có gồ ghề nham nhở như trong trường hợp mà các bạn nhìn thấy một cái subpleural consolidation mà nó do viêm phổi gây nên. Thì đó là một cái điểm khác biệt rất lớn. Điều thứ hai nữa là cái clinical context. ví dụ như là các bạn thấy một cái bệnh nhân mà đau ngực này, cái kiểu đau như là kiểu đau màng phổi á, thì các bạn sẽ sử dụng ngay cái đầu giò, các bạn sẽ tìm ở cái vùng đó. Thường cái vùng mà bệnh nhân nói là đau ngực đó, khi ta siêu âm thì chắc chắn cái vùng mà nó sẽ gây nên cái đau ngực đó là những cái tổn thương từ ngoại biên. Mình sẽ nhìn thấy ngay được những cái tổn thương mà ngay từ màng phổi đi vào, thì nếu rất là may mắn thì mình sẽ nhìn thấy được cái hình C-line này hay là cái pulmonary infarction này. Nhưng thêm vào nữa thì bao giờ chúng ta cũng phải nhớ là focus, tức là siêu âm đa cơ quan, siêu âm nhiều cơ quan, thì lúc đó mình sẽ phải sử dụng thêm cả cái hình ảnh siêu âm tim nó như thế nào. Nếu một cái hình ảnh siêu âm tim như các bạn nhìn thấy ở trên cái clip này, với một cái hình ảnh thất phải nó giãn rất là lớn và nó có hình V-shape septal như thế này, thì là một cái dấu hiệu mà gợi ý rất là nhiều về cái thuyên tắc phổi. Còn nếu như mà tùy vào cái tình trạng huyết động của bệnh nhân, nếu như mà tình trạng huyết động của bệnh nhân ổn định thì mình có thể nghĩ rằng là tình trạng huyết động bệnh nhân ổn định mà mình muốn đi tìm tiêu chuẩn vàng thì mình phải chuẩn dùng cái CTA để cái chẩn đoán. Rồi, so I will move to the other question. So according to the study of Dr. Gattinoni, in COVID-19 pneumonia, we have two types of the lung injury. The first type is the L type. It means the low elastin. And the second is the H type. It means the high elastin. And so, can you, with the lung ultrasound, can you differentiate from the type 1 and type 2? This is a question for COVID-19.
Okay, yeah, this is a very nice question. So, of course, the differentiation from Luciano Gattinoni doesn't rely on lung ultrasound, but you can, help to distinguish the H type and the low type of your lung, because very simply, I'm trying to make this this quite complex concepts simply. If you have a less deaerated lung, like in this example, so the second CT of our patients, this lung, it is less compliant, okay? So it is a heavier lung, it is much less compliant, okay? And it is quite different from the same patient a few days ago, a few days before, but with a better lung. So here we have a more aerated lung, so we have a higher compliance in this case, okay? Because the lung is less heavy. So somehow these two pictures in the same patient can be a paradigm for the H type and the L type, because the less consolidations you see, as in this case, so if you have separated B-lines or even a little bit of coalescent B-lines but not consolidations, the lung is more compliant, is less heavy. But if you have this picture with more consolidations, less aeration of the lung, you have a heavier lung and less compliant lung. So I would say yes, in a very rough way, lung ultrasound can help you to distinguish the H and L type of Gattinoni.
Mình đọc tắt lại câu trả lời của Dr. Gargani là với hình ảnh siêu âm phổi này có thể chẩn đoán được hai cái tip này. Tip thứ nhất là tip cái high elastin. Thì với high elastin thì cái tỷ trọng của phổi nó sẽ tăng lên rất nhiều, và nó có hình ảnh là cái đông đặc phổi nó sẽ nhiều hơn. Còn nếu như mà cái tip mà L tức là low elastin thì cái phổi nó có vẻ như là nó không có đông đặc, và nó chỉ có từ separated B-line cho đến multiple B-line, chứ nó không có nhiều cái consolidation như là trường hợp cái tip mà high elastin. Đó là câu trả lời của Dr. Luna. So the second question is For the trans-lobar, if you find the trans-lobar consolidation in the patient with the COVID-19 pneumonia, do you think that is the lung ultrasound finding suggesting the superimposed bacterial infection, or this is the progressive of the COVID-19 patient?
Mm-hmm. So, I mean, I have to make some compliments to the audience because your questions are really smart. The answer is we don't know. I have to say, at first, we thought that when we saw large consolidations in these patients, it could be a sign of superimposed bacterial pneumonia. But actually, later on in the weeks, we saw that some patients without clear signs of bacterial superinfection also could develop larger consolidations. So actually, it is really hard to say. You cannot rely only on lung ultrasound for that. I can tell you that, I mean, in my experience, but this is only empirical experience, the intensivists I work with, when they saw the large consolidations, anyway, they also started an antibacterial antibiotic treatment. So even if they were not sure it was a superimposed bacterial pneumonia, they treated it also as it was, and it never turned to be bad. But to be honest, we cannot be sure how to distinguish very severe COVID or a superimposed bacterial pneumonia.
It means we can add some more antibiotic, or you can make some more lab tests to confirm that the patient have a bacterial infection.
Yeah, but it is, the thing is that you do that for a precaution, but you can never be so sure that you did it right, because if the patient is going better, you cannot know that it was due to your antibiotic or because you are also treating COVID somehow, though we don't have specific drugs for COVID. So it remains quite gray zone. But I mean, in these cases, of course, it is better maybe to give something more than something less. So if you tell me it is reasonable to add antibiotics when you see large consolidations, I would say yes, it is reasonable, and I would do that, even if I cannot be sure that that large consolidation is not just the severe expression of the COVID disease and not a bacterial superinfection.
So I will translate into Vietnamese this question. Câu hỏi là tức là trong trường hợp mà mình nhìn thấy một cái khối đông đặc phế nang xuyên tử thùy rất là lớn ấy, thì câu hỏi của audience là với cái trường hợp này thì mình sẽ chẩn đoán đây là một cái bội nhiễm của bệnh nhân viêm phổi, bội nhiễm do nhiễm khuẩn, do nhiễm vi khuẩn trên nền bệnh nhân COVID-19, hay là đây là hình ảnh tiến triển của một cái bệnh nhân COVID-19 mà tiến triển nặng. Thì câu trả lời của Dr. Luna là mình sẽ không thể sử dụng cái siêu âm phổi để chẩn đoán phân biệt trong hai cái trường hợp này, mà một cách là khôn ngoan hơn thì chúng ta sẽ sử dụng kháng sinh. Đương nhiên là chúng ta có thể dùng thêm các test khác, bởi vì chúng ta biết rằng là ngay cả trong trường hợp mà COVID-19 mà tiến triển nặng đi chăng nữa thì chúng ta cũng chưa có cái biện pháp nào điều trị đặc hiệu đối với lại là viêm phổi do COVID-19, cho nên chúng ta sẽ thêm vào một cái kháng sinh trong cái trường hợp mà chúng ta nhìn thấy trong cái quá trình mà theo dõi bệnh nhân tại giường, chúng ta đánh giá bệnh nhân mà chúng ta thấy có sự khác biệt về cái khối đông đặc phế nang này so với những ngày trước, thì chúng ta có thể sử dụng thêm kháng sinh để nghĩ rằng là nhiều khả năng là bệnh nhân này có tiến triển nặng của cái bội nhiễm vi khuẩn trên nền mà cái nhiễm trùng viêm phổi do COVID-19. Đó là câu trả lời của Dr. Luna. Any question? Bạn nào có câu hỏi nào nữa?
Dạ, cho hỏi mình còn câu hỏi nào để đặt cho Dr. Luna nữa không ạ? Không thì em xin kết thúc chương trình ạ.
Okay, that's all the questions sent from the audience. So thank you so much, Dr. Luna, for very smart answer and very comprehensive answer also.
Okay, thanks to you. It was a pleasure to be with you. I hope this was useful, and I hope you're going to use a lot your ultrasound to help your clinical work. It is really a revolution. At least I can speak for myself and all the colleagues that has done courses in lung ultrasound. They come after a few months and say, okay, you really changed my life and my clinical practice.
Okay, thank you. Thank Dr. Luna Gargani for joining us today and sharing lots of interesting experience. Và rất cảm ơn bác sĩ Hồng Anh đã tham dự cùng bọn em trong cái chương trình này. Kính thưa toàn thể quý bác sĩ, chương trình hội thảo trực tuyến về siêu âm phổi trong hồi sức cấp cứu vì sao, khi nào và làm thế nào xin được kết thúc tại đây. Một lần nữa xin được chân thành cảm ơn tiến sĩ bác sĩ Luna Gargani, giáo sư tiến sĩ Nguyễn Gia Bình, thạc sĩ bác sĩ Đỗ Hồng Anh và Hội hồi sức cấp cứu và chống độc Việt Nam đã giúp đỡ hoàn thành chương trình. Xin trân trọng cảm ơn sự tham dự của toàn thể quý bác sĩ. Hội thảo đến đây là kết thúc. Xin trân trọng cảm ơn sự tham dự của quý bác sĩ. Xin cảm ơn.
Okay, so let me say thank you to Dr. Luna Gargani again for the very comprehensive and excellent presentation. And I would like to thank also the Philips POC Việt Nam to bring Dr. Luna to Vietnam. And I hope that in the near future, with the great support of the Philips POC, that we can have more webinar to Dr. Luna Gargani. So last but not least, I would like to thank all of you for the great audience, all of you from the community of the emergency and critical care, spending the weekend time to join this interesting webinar. So thank you so much. Okay.
Thank you.
Bye.
Thank you. Bye-bye.
Bye-bye.